Question 1. A nurse is assessing a patient with suspected diabetes insipidus, DI. Which clinical manifestation would the nurse most expect to find? A. Oliguria and fluid retention. B. Polyuria and polydipsia. C. Hyperglycemia and ketonuria. D. Hyponatremia and cerebral edema. Answer, B. Polyuria and polydipsia. This question assesses your knowledge of the primary clinical presentation of diabetes insipidus, DI, an endocrine disorder affecting antidiuretic hormone, ADH, secretion or renal response. The keywords diabetes insipidus directly point to issues with water balance, and its hallmark signs are excessive urination, polyuria, and extreme thirst, polydipsia, as the body attempts to compensate for massive fluid loss. Patients with DI cannot conserve water, leading to dilute urine output, which drives the intense thirst. For example, a patient might report drinking gallons of water a day and waking multiple times at night to urinate. Remember, think DI for draining inside, lots of dilute urine. Question 2. A patient with diabetic ketoacidosis, DKA, is receiving an insulin drip. The nurse notes a potassium level of 2.8 milliequivalent/L. What is the most appropriate nursing action? A. Continue the insulin drip as prescribed and monitor potassium. B. Stop the insulin drip and administer potassium intravenously. C. Increase the insulin drip rate to lower blood glucose faster. D. Administer oral potassium supplement and notify the physician. Answer, B. Stop the insulin drip and administer potassium intravenously. This question tests your critical understanding of potassium management during insulin therapy for diabetic ketoacidosis, DKA, a common and critical endocrine emergency. The keyword potassium level of 2.8 milliequivalent/L indicates severe hypokalemia, which is a life-threatening electrolyte imbalance. Insulin drives potassium into cells, further lowering serum potassium, so continuing the drip without addressing severe hypokalemia could lead to dangerous cardiac arrhythmias. Therefore, the priority is to temporarily stop the insulin drip and administer intravenous potassium to correct this critical deficit before resuming insulin. Remember, potassium before insulin is a crucial safety principle in DKA management to prevent life-threatening dysrhythmias. Question 3. A nurse is caring for a patient admitted with syndrome of inappropriate antidiuretic hormone, SIAD. Which laboratory finding would the nurse anticipate? A. Serum sodium 148 milliequivalent/L. B. Serum osmolality 295 mosm/kg. C. Urine-specific gravity 1,030. D. Decreased urine sodium. Answer, C. Urine-specific gravity 1,030. This question evaluates your understanding of the expected laboratory findings in syndrome of inappropriate antidiuretic hormone, SIAD, an endocrine disorder characterized by excessive ADH. The key clue SIAD indicates too much water retention and dilutional hyponatremia. The kidneys continue to reabsorb water, leading to concentrated urine, which is reflected by a high urine-specific gravity, above 1,020. Conversely, serum sodium and osmolality would be low due to the dilutional effect, and urine sodium would typically be elevated as the body tries to excrete sodium with the excess water. For instance, a patient with SIAD might have a very low serum sodium, e.g., 120 milliequivalent/L, while producing very concentrated urine. Always associate SIAD with soaked inside, meaning concentrated urine and diluted blood. Question 4. A patient is admitted with a pheochromocytoma crisis. The nurse anticipates administering medication to primarily manage which life-threatening symptom? A. severe hypoglycemia. B. Profound hypotension. C. Hypertensive crisis. D. Hyperkalemia. Answer: C. Hypertensive crisis. This question tests your knowledge of the primary life-threatening complication and its management in a pheochromocytoma crisis, an endocrine emergency caused by a tumor releasing excessive catecholamines. The keyword pheochromocytoma crisis immediately points to massive catecholamine release, which results in extreme and often paroxysmal hypertension. This severe hypertension puts the patient at high risk for stroke, myocardial infarction, and renal failure. Therefore, the priority medication administration will be focused on controlling this hypertensive crisis, typically with alpha blockers. For example, the patient may present with blood pressures exceeding 200/100 mmHg. Remember, pheochromocytoma equals P4 pressure, dangerously high blood pressure. Question 5. A nurse is educating a patient newly diagnosed with hypothyroidism about their medication. Which instruction is most important for the nurse to include? A. Take the medication with antacids to prevent stomach upset. B. Take the medication on an empty stomach with water, at the same time each day. C. Stop the medication if symptoms improve to avoid overdose. D. Expect immediate relief of symptoms within a few days of starting treatment. Answer: B. Take the medication on an empty stomach with water, at the same time each day. This question focuses on crucial patient education regarding thyroid hormone replacement therapy for hypothyroidism, a common endocrine condition. The keyword hypothyroidism implies the patient will be taking a synthetic thyroid hormone like levothyroxine. Taking levothyroxine on an empty stomach, usually 30 to 60 minutes before breakfast, is essential because food, especially calcium-containing foods or supplements and antacids, can significantly impair its absorption, reducing its effectiveness. Consistent timing each day helps maintain stable hormone levels. It's important for patients to understand that symptoms improve gradually, and this medication is typically for lifelong use. Think of thyroid medication as needing its own quiet time to be properly absorbed, away from other things in your stomach. Question 6. A patient is experiencing adrenal crisis following abrupt discontinuation of corticosteroids. The nurse would prioritize which intervention? A. Administering oral corticosteroids. B. Initiating fluid restriction. C. Administering intravenous hydrocortisone. D. Monitoring for hyperglycemia. Answer: C. Administering intravenous hydrocortisone. This question evaluates your understanding of the immediate life-saving intervention for an adrenal crisis, a severe endocrine emergency. The keywords adrenal crisis and abrupt discontinuation of corticosteroids indicate a critical deficiency of cortisol, leading to profound physiological instability. Intravenous hydrocortisone, a glucocorticoid, is the immediate treatment to replace the missing cortisol and stabilize the patient's condition. Oral corticosteroids would not be appropriate for a critically ill patient, and fluid restriction would worsen the hypovolemia often seen in adrenal crisis, while hyperglycemia is less of a primary concern than the adrenal insufficiency itself. For example, a patient in adrenal crisis may present with severe hypotension and shock. Always remember that an adrenal crisis requires immediate 4-glucocorticoid replacement to prevent circulatory collapse. Question 7. A critical care nurse is managing a patient with hyperosmolar hyperglycemic state, HHS. What is the priority intervention for this patient? A. Administering a rapid-acting insulin bolus. B. Correcting electrolyte imbalances, especially potassium. C. Aggressive intravenous fluid resuscitation. D. Initiating a bicarbonate infusion. Answer C. Aggressive intravenous fluid resuscitation. This question assesses your knowledge of the priority treatment for hyperosmolar hyperglycemic state, HHS, a severe endocrine complication of uncontrolled diabetes. The key clue, hyperosmolar hyperglycemic state, indicates extreme dehydration and hyperosmolarity, often with significantly elevated blood glucose levels. While insulin and electrolyte correction are important, the immediate life-threatening issue in HHS is severe dehydration and hypovolemic shock. Therefore, aggressive intravenous fluid resuscitation to restore intravascular volume and gradually lower serum osmolality is the absolute priority. For instance, a patient with HHS might have a serum osmolality over 320 mosm/kg and significant fluid deficits. Remember, HHS means heavy hydration starts, fluids first. Question 8. A patient is admitted with a thyroid storm. Which clinical manifestation is most indicative of this condition? A. Bradycardia and hypothermia. B. Extreme tachycardia and hyperthermia. C. Hypoglycemia and lethargy. D. Hyporeflexia and dry skin. Answer B. Extreme tachycardia and hyperthermia. This question tests your recognition of the hallmark clinical signs of a thyroid storm, a life-threatening exacerbation of hyperthyroidism. The term thyroid storm implies an overwhelming surge of thyroid hormones, leading to a hypermetabolic state. The key indicators of this crisis are extreme tachycardia, heart rate often greater than 140 bpm, severe hyperthermia, fever greater than 104 degrees Fahrenheit or 40 degrees C, and exaggerated nervous system effects such as agitation or delirium. Other options describe signs of hypothyroidism or are not characteristic of thyroid storm. For example, a patient in thyroid storm may present with a rapid, irregular heartbeat, high fever, and altered mental status. Think of thyroid storm as the body's systems being on overdrive. Question 9. A nurse is preparing to administer intravenous calcium gluconate to a patient with severe symptomatic hypocalcemia. What is a critical nursing consideration during this administration? A. Administering it rapidly via forepush to quickly raise calcium levels. B. Monitoring for hypernatremia. C. Administering slowly and monitoring for cardiac arrhythmias. D. Mixing it with a bicarbonate solution for optimal absorption. Answer C. Administering slowly and monitoring for cardiac arrhythmias. This question focuses on safe administration of intravenous calcium, particularly in the context of severe hypocalcemia, an electrolyte imbalance that can have significant endocrine implications, e.g., with hypoparathyroidism. The keywords intravenous calcium gluconate and severe symptomatic hypocalcemia highlight the need for careful administration. Rapid administration of calcium can cause severe cardiac arrhythmias, including bradycardia and asystole, due to its direct effect on myocardial contractility. Therefore, it must be administered slowly, typically over 10 to 20 minutes, with continuous cardiac monitoring. Mixing with bicarbonate is contraindicated as it forms a precipitate, and hypernatremia is not a direct concern with calcium administration. For instance, a patient receiving 4 calcium should be on a cardiac monitor to observe for changes in rhythm. Always remember, slow down, calcium, for a healthy heart. Question 10. A patient presents with classic signs of myxedema coma. Which assessment finding is most critical for the nurse to immediately address? A. Pitting edema in the extremities. B. Generalized muscle weakness. C. Hypoventilation and respiratory acidosis. D. Hair loss and brittle nails. Answer C. Hypoventilation and respiratory acidosis. This question asks you to identify the most critical, life-threatening finding in a patient experiencing myxedema coma, which is the severe form of hypothyroidism, an endocrine emergency. The keywords myxedema coma indicate a profound decrease in metabolic rate affecting all body systems. Due to severe metabolic depression, these patients often develop hypoventilation, leading to carbon dioxide retention and respiratory acidosis, which can quickly become fatal if not managed. While other findings like edema and weakness are present, respiratory compromise is an immediate threat to life. For example, a patient in myxedema coma might have a shallow respiratory rate and depressed mental status. Always remember, in myxedema coma, myxedema means low, including respirations, so prioritize breathing. Question 11. A nurse is providing discharge teaching to a patient newly diagnosed with Addison's disease. Which instruction is most crucial for the patient to understand? A. Increase sodium intake to prevent fluid retention. B. Carry an emergency supply of corticosteroids and wear a medical alert bracelet. C. Take all medications at bedtime to promote sleep. D. Avoid all forms of exercise to prevent adrenal fatigue. Answer B. Carry an emergency supply of corticosteroids and wear a medical alert bracelet. This question tests your understanding of essential patient education for managing Addison's disease, a chronic endocrine disorder characterized by adrenal insufficiency. The keyword Addison's disease implies a chronic lack of cortisol and aldosterone, placing the patient at risk for adrenal crisis during periods of stress, illness, or injury. Carrying an emergency supply of corticosteroids and wearing a medical alert bracelet are crucial safety measures that ensure immediate treatment can be administered if the patient experiences an adrenal crisis and cannot communicate. Avoiding all exercise is unnecessary, and timing of medication needs to be tailored. For example, during a febrile illness, the patient would need to increase their corticosteroid dose. Always teach patients with Addison's to be prepared. Be protected for potential crises. Question 12. A patient with hyperosmolar hyperglycemic state, HHS, has a blood glucose of 800 mg per deciliter. The nurse is preparing to administer insulin. What type of insulin is typically used in the initial management of HHS? A. NPH insulin. B. Regular insulin for infusion. C. Glargine insulin. D. Insulin aspart subcutaneously. Answer B. Regular insulin for infusion. This question assesses your knowledge of the appropriate insulin therapy for the acute management of hyperosmolar hyperglycemic state, HHS, a severe endocrine emergency. The keywords HHS and blood glucose of 800 mg per deciliter indicate a need for rapid and controlled glucose lowering. Regular insulin administered as a continuous intravenous infusion is the standard treatment for HHS and DKA because it allows for precise titration and a steady decrease in blood glucose levels, minimizing the risk of rapid fluid shifts or cerebral edema. Subcutaneous insulins or longer-acting insulins are not appropriate for the immediate critical care management of severe hyperglycemia. Remember, for immediate response is key in hyperglycemic crises. Question 13. A nurse is assessing a patient with a suspected pheochromocytoma. Which symptom cluster would most strongly suggest this diagnosis? A. Hypotension, bradycardia, and weight gain. B. Paroxysmal hypertension, palpitations, and diaphoresis. C. Hypoglycemia, fatigue, and cold intolerance. D. Polyuria, polydipsia, and weight loss. Answer B. Paroxysmal hypertension, palpitations, and diaphoresis. This question tests your ability to recognize the classic symptom triad of pheochromocytoma, a rare tumor of the adrenal medulla that secretes excessive catecholamines. The term pheochromocytoma should alert you to overstimulation of the sympathetic nervous system. The characteristic symptoms include sudden, severe episodes of hypertension, paroxysmal hypertension, a rapid and forceful heartbeat, palpitations, and excessive sweating, diaphoresis. These symptoms are directly related to the surges of norepinephrine and epinephrine released by the tumor. For example, a patient might experience sudden, severe headaches along with these symptoms. Remember the PPD triad for pheochromocytoma: paroxysmal hypertension, palpitations, and diaphoresis. Question 14. A patient with diabetic ketoacidosis, DKA, has a serum bicarbonate of 10 milliequivalent/L and a pH of 7/18. Which treatment would the nurse anticipate being prescribed if severe acidosis persists despite initial fluid and insulin therapy? A. Sodium chloride 0.9% infusion. B. Potassium chloride infusion. C. Sodium bicarbonate infusion. D. Dextrose 5% in water. Answer: C. Sodium bicarbonate infusion. This question assesses your understanding of when sodium bicarbonate therapy might be considered in diabetic ketoacidosis, DKA, a critical endocrine emergency. The keywords DKA, pH of 7/18, and severe acidosis persists despite initial fluid and insulin are crucial. While fluid resuscitation and insulin are the primary treatments, bicarbonate therapy may be considered for severe metabolic acidosis, pH 7.0 or 7.1, that does not improve after initial volume expansion and insulin. It is not routinely given because it can worsen hypokalemia and cause cerebral edema, so it's reserved for extreme cases. For instance, a patient might receive bicarbonate if their cardiac function is significantly compromised by severe acidosis. Remember, bicarbonate in DKA is a last resort for very low pH, not a first-line treatment. Question 15. A patient with chronic kidney disease develops secondary hyperparathyroidism. What is the primary reason for this complication? A. Inability of the kidneys to excrete phosphate, leading to hyperphosphatemia. B. Increased production of vitamin D by the diseased kidneys. C. Direct stimulation of the parathyroid glands by uremic toxins. D. Excessive dietary calcium intake due to a restricted diet. Answer: A. Inability of the kidneys to excrete phosphate, leading to hyperphosphatemia. This question explores the pathophysiology of secondary hyperparathyroidism, a common endocrine complication in patients with chronic kidney disease. The key clues, chronic kidney disease and secondary hyperparathyroidism, point to a renal cause. As kidneys fail, they lose the ability to excrete phosphate, leading to hyperphosphatemia. This high phosphate level then binds with calcium, reducing serum calcium, hypocalcemia, which in turn stimulates the parathyroid glands to produce more parathyroid hormone, PTH, in an attempt to raise calcium levels, resulting in secondary hyperparathyroidism. The kidneys also fail to activate vitamin D, further impairing calcium absorption. For example, a patient with CKD might have persistently high phosphate and PTH levels. Remember, in CKD, phosphate retention drives PTH production. Question 16. A nurse is monitoring a patient with SIAD who is receiving hypertonic saline. What is the most important assessment to perform to prevent a serious complication? A. Hourly blood glucose levels. B. Urine output every 4 hours. C. Neurological status frequently. D. Daily weights only. Answer C. Neurological status frequently. This question highlights a critical safety concern when treating syndrome of inappropriate antidiuretic hormone, SIAD, with hypertonic saline. The keywords SIAD, hypertonic saline, and serious complication should immediately bring to mind the risks associated with rapid correction of hyponatremia. Too rapid correction of hyponatremia can lead to osmotic demyelination syndrome, formerly central pontine myelinolysis, a devastating neurological disorder. Therefore, frequent neurological assessments are paramount to detect any changes that could indicate this complication. While other assessments are important, neurological status directly monitors for this severe adverse effect. For instance, any new weakness, confusion, or difficulty speaking could signal this complication. Always remember, too fast a fix can cause a neurological crisis when correcting hyponatremia. Question 17. A patient experiencing severe hypoglycemia is conscious but disoriented. What is the most appropriate initial nursing intervention? A. Administer glucagon subcutaneously. B. Provide 15 to 20 grams of a simple carbohydrate orally. C. Prepare to administer intravenous D50W. D. Give a complex carbohydrate with protein. Answer B. Provide 15 to 20 grams of a simple carbohydrate orally. This question assesses your knowledge of the immediate management of mild to moderate hypoglycemia in a patient who is conscious, an important endocrine emergency. The keywords severe hypoglycemia, conscious but disoriented indicate the patient can still swallow safely. For a conscious patient, the most appropriate initial intervention is to administer 15 to 20 grams of a simple carbohydrate orally, such as juice, glucose tablets, or regular soda, to rapidly raise blood glucose. Intravenous D50W is for unconscious patients, and glucagon is for severe hypoglycemia when oral intake is not possible, but the patient is conscious here. For example, giving 4 ounces of orange juice is a common way to provide this carbohydrate. Remember, for conscious patients, oral glucose first for the fast fix. Question 18. A patient is admitted with a new diagnosis of Cushing's syndrome. The nurse anticipates finding which classic physical manifestation? A. Weight loss, exophthalmos, and heat intolerance. B. Moon face, buffalo hump, and purple striae. C. Tachycardia, diaphoresis, and hypertension. D. Bradycardia, coarse hair, and cold intolerance. Answer B. Moon face, buffalo hump, and purple striae. This question tests your ability to identify the characteristic physical signs of Cushing's syndrome, an endocrine disorder caused by prolonged exposure to high levels of cortisol. The term Cushing's syndrome should immediately make you think of the distinctive body changes caused by excess cortisol. These include a rounded, full face, moon face, a fatty hump between the shoulders, buffalo hump, and thin, fragile skin with reddish-purple stretch marks, striae, on the abdomen and thighs. Other options describe hyperthyroidism, pheochromocytoma, or hypothyroidism. For instance, a patient might also have truncal obesity with thin extremities. Remember, for Cushing's, think Cushing's. Central obesity, unusual hair growth, skin changes, high blood pressure. Question 19. A critical care nurse is managing a patient with diabetes insipidus, DI, who is receiving desmopressin, DAP. Which assessment finding indicates the medication is effective? A. Increased urine output. B. Decreased serum sodium. C. Decreased urine-specific gravity. D. Increased blood pressure. Answer B. Decreased serum sodium. This question evaluates your understanding of the therapeutic effect of desmopressin, DAP, in treating diabetes insipidus, DI, an endocrine condition characterized by excessive water loss. Desmopressin is a synthetic analog of ADH, which helps the kidneys reabsorb water. If the medication is effective, the patient will retain water, leading to a decrease in urine output and an increase in urine-specific gravity as the urine becomes more concentrated. The increased water retention will also cause the serum sodium to decrease towards a normal range due to hemodilution. For example, a patient's serum sodium might drop from 155 milliequivalent/L to 140 milliequivalent/L, and their urine output would significantly decrease. Remember, effective DAP means don't drain all the volume, water retention, and diluted serum. Question 20. A patient with pancreatic insufficiency is at risk for impaired absorption of which fat-soluble vitamins? A. Vitamin C and B12. B. Vitamin A, D, E, and K. C. Folic acid and niacin. D. Thiamine and riboflavin. Answer B. Vitamin A, D, E, and K. This question addresses the exocrine function of the pancreas and its impact on nutrient absorption, which can have endocrine-related consequences if nutrition is severely compromised. The keyword pancreatic insufficiency means the pancreas is not producing enough digestive enzymes, particularly lipase, which is essential for fat digestion. Without adequate fat digestion, the absorption of fat-soluble vitamins, A, D, E, K, is significantly impaired, leading to potential deficiencies. Water-soluble vitamins are not affected in the same way. For example, a patient with chronic pancreatitis might develop night blindness, vitamin A deficiency, or bleeding issues, vitamin K deficiency. Always remember, fat-soluble vitamins need fat, and pancreatic enzymes help digest it. Question 21. A nurse is reviewing the arterial blood gases, ABGs, of a patient with suspected diabetic ketoacidosis, DKA. Which finding is most consistent with DKA? A. pH 7, 48, PaCO 230 mm of mercury, HCO 326 milliequivalent/L. B. pH 7, 20, PaCO 230 mm of mercury, HCO 312 milliequivalent/L. C. pH 7, 35, PaCO 245 mm of mercury, HCO 322 milliequivalent/L. D. pH 7, 40, PaCO 230 mm of mercury, HCO 318 milliequivalent/L. Answer B. pH 7, 20, PaCO 230 mm of mercury, HCO 312 milliequivalent/L. This question tests your ability to interpret arterial blood gas, ABG, results characteristic of diabetic ketoacidosis, DKA, a major endocrine emergency. The keyword DKA signifies a state of metabolic acidosis due to ketone production. Therefore, you would expect a low pH, acidemia, and a low bicarbonate, HCO3, indicating a metabolic derangement. The PaCO2 may be normal or low if the patient is compensating with Kussmaul respirations. A pH of 7, 20 and HCO3 of 12 milliequivalent/L clearly shows an uncompensated or partially compensated metabolic acidosis. For example, a patient with DKA may be hyperventilating to blow off CO2, which is the body's attempt to raise the pH. Remember, DKA means low pH and low bicarb. Question 22. A patient with hyperthyroidism is diagnosed with exophthalmos. What is the most important nursing intervention for this patient? A. Administering antithyroid medications to reverse eye changes. B. Applying warm compresses to the eyes to reduce discomfort. C. Protecting the eyes from dryness and injury. D. encouraging frequent eye rubbing to improve circulation. Answer C. Protecting the eyes from dryness and injury. This question focuses on the essential nursing care for a patient experiencing exophthalmos, an ocular complication often associated with hyperthyroidism, specifically Graves' disease. The keyword exophthalmos refers to the bulging of the eyes, which can lead to incomplete eyelid closure, corneal dryness, and increased risk of corneal abrasions or ulceration. Antithyroid medications may not fully reverse the eye changes, and warm compresses or eye rubbing are not the primary interventions. Therefore, protecting the eyes from dryness and injury with artificial tears, lubricating gels, and potentially taping eyelids shut at night is paramount. For example, patients might need to wear sunglasses outdoors and use eye drops frequently. Always remember, for exophthalmos, protect those precious peepers. Question 23. A patient with a history of adrenal insufficiency develops severe abdominal pain, vomiting, and hypotension after a stressful event. The nurse recognizes these as signs of A. Hyperosmolar hyperglycemic state, HHS. B. Thyroid storm. C. Adrenal crisis. D. Diabetic ketoacidosis, DKA. Answer C. Adrenal crisis. This question assesses your ability to recognize the classic presentation of an adrenal crisis, a life-threatening endocrine emergency. The keywords adrenal insufficiency, severe abdominal pain, vomiting, and hypotension, and stressful event are all hallmarks. During stress, like illness, surgery, or trauma, the body needs more cortisol. In adrenal insufficiency, there's not enough cortisol, leading to a profound collapse of the circulatory system and severe gastrointestinal symptoms. HHS, thyroid storm, and DKA have different clinical presentations. For instance, the patient's blood pressure might be critically low and unresponsive to fluids. Remember, stress plus adrenal insufficiency equals crisis. Question 24. Which finding is a key difference between diabetic ketoacidosis, DKA, and hyperosmolar hyperglycemic state, HHS? A. Presence of severe hyperglycemia in both conditions. B. Metabolic acidosis being more pronounced in DKA. C. Significant ketonuria being common in HHS. D. Profound dehydration being absent in DKA. Answer B. Metabolic acidosis being more pronounced in DKA. This question focuses on distinguishing between two major endocrine emergencies, diabetic ketoacidosis, DKA, and hyperosmolar hyperglycemic state, HHS. While both involve severe hyperglycemia, the defining difference is the presence of significant metabolic acidosis in DKA due to the accumulation of ketones, which is usually absent or very mild in HHS. Ketonuria is characteristic of DKA, not HHS, and profound dehydration is present in both, although often more severe in HHS. For example, a DKA patient will have a low pH and bicarbonate, while an HHS patient's pH and bicarbonate are typically normal or only slightly deranged. Always remember, DKA equals ketones and acidosis, HHS equals hyperosmolar, no, or minimal. Acidosis. Question 25. A patient with long-standing diabetes presents with confusion, slurred speech, and tremors. Blood glucose is 45 milligrams per deciliter. What is the most important immediate action for the nurse to take? A. Administer a rapid-acting insulin dose. B. Check the patient's urine for ketones. C. Administer 4-dextrose 50%, D50W. D. Offer a high-fiber snack to raise blood glucose gradually. Answer C. Administer 4-dextrose 50%, D50W. This question assesses your knowledge of the immediate management of severe hypoglycemia in an altered patient, an urgent endocrine emergency. The keywords confusion, slurred speech, tremors, and blood glucose is 45 mg per deciliter indicate severe hypoglycemia with neurological impairment, meaning the patient cannot safely take oral glucose. In such a situation, intravenous dextrose 50%, D50W, is the most rapid and effective way to raise blood glucose and reverse the neurological symptoms. Administering insulin would worsen the hypoglycemia, and a high-fiber snack would be too slow and unsafe. For example, after D50W, the patient's mental status should rapidly improve. Always remember, for an unconscious or severely altered hypoglycemic patient, D50W is the way to go.